Very much, Lise. Next speaker is Jens Lassen, and he represents the European Bifurcation Club. I think it's some kind of Freemasonry, isn't it?
Well. Thank you very much, dear Chairman, for inviting me again. Thank you to Jim. It's a pleasure to be here. And Freemason, maybe, let's see. So I'm going to discuss the EBC perspective on left main stenting, and I'll try to run through why we focus on that topic exactly at this time, and I'll try to give you a little background on the reason for ending here. These are my disclosure statements, so I guess make it pretty clear what I'm going to talk about. It is very interesting to know, I guess, especially here in Snowmass, that the European Bifurcation Club was founded in 2005. The idea was formulated in 2004. In 2004, I gave a speech on the Nordic bifurcation studies in this meeting. And after the speech, the day after, which was a Wednesday, I took the high alpine lift, the old one, which is not there anymore. And as you remember, it was a two-chair. I was sitting beside Thierry Lefebvre, and halfway up, he asked me if I would like to join the initiation of a club focusing on bifurcations. So actually, I can say that at least a part of the European Bifurcation Club idea is concepted in this meeting. We moved on. The idea of the meeting was based on the success of the Japanese CTO club. We need a think tank, not only by physicians, but also by scientists, pathologists, biochemists, and engineers to discuss all topics around how to stent and how to treat bifurcation in the human coronary arteries. We became not a Freemasonship, but a formal and independent club in 2012. We have one yearly scientific meeting, and we publicate one consensus statement a year, which is pretty much downloaded. The next meeting will be in Portugal in October. But this is coming back to the left main stenting. What those guidelines actually tells us. These are the guidelines and recommendation for left main stenting in the States and in Europe. And you can see that in the States, it defined that low syntax score below 22, it's a 1B for CABITS and a 2AB for PCI. And it's a 1B for the same group in Europe. Going downwards to syntax scores at 32, there's the same recommendation in the States and in Europe. But these recommendations are, as you can see, from 2011 and 2014, and the recommendation might change in the near future based on the two new trials in the area, the Excel trial and the Noble trial. I won't go into very much detail with the trials. There have been a lot of debates on them, but they are the largest and the newest trial on left main stenting. Remember the syntax trial, and remember that we divide the guidelines in syntax scores. And again, remember that the syntax score is actually a post hoc made analysis from the initial syntax trial, which means that in that way, those patients were treated. This is the risk score based on that patient's, a kind of a circular conclusion. But that is what we have. But there are some quite interesting results from the Excel and Noble trial I'll run through with you. Both the trials were designed to have a syntax score below 32. Actually, the mean syntax score was 20.6 in the Excel and 22.5 in the Noble. So it's in the lower immediate range. This is actually the result from the Noble trial based on syntax score, and quite surprisingly, CABITS do much better in the lower syntax score. But try to look into it. It's quite intuitive that it should be so, because these are very easy patients for an operation as well, with good takeoff arteries. And there was periprocedural infarction included in the endpoints. On the other hand, it seems that there was no differences in the intermediate syntax score, and there was no statistical significant differences between PCI and CABITS in the high syntax score. It's difficult to really elaborate on what is going on here, but one thing seems pretty clear. The syntax score might not be very good as a risk indicator for surgery, which means that it's maybe not the right thing to make the evaluation of guidelines on when or not to embark on a left main stenting. But that needs to be discussed. So, after the Excel and Noble trial, it seems that the syntax score is more or less outdated. But if we should come to a kind of a forecast of what will happen in the next guidelines, the low and the intermediate categories will maybe be collapsed, which means that there will be equality between CABITS and PCI for syntax scores below 33. And again, we think that the PCI or CABITS revascularization recommendation will be upgraded to an A in both guidelines, but we'll see. The guidelines discussing are ongoing. But based on these discussions, we think in the EBC that from the future, it would be very easy and possible to embark on left main stenting for syntax score below or equal to 32, and of course in a surgical turned down patient. All in all, it will mean an increase in left main stenting. So this was one of the minutes from the EBC meeting in Amsterdam, in Rotterdam this year. And we concluded that it would be highly important to discuss the technical solution of left main stenting in the near future. This was held in October, and Noble and Excel was presented later on in November at TCT. So focus on the stenting techniques in the Noble and the Excel, and insight from bench head testing and intravascular imaging will be highly important in that discussion. And I'll try to run through some of the background for these conclusions. Actually, you have to be aware of that in the Noble trial, 88% of the left mains was distal left main with involvement of both the LAD and circumflex, and it was 81% in the Excel trial. And again, you have to be aware that 35% of the bifurcation in the Noble received tooth stents. And these are figures that we need to have in mind when discussing how to do it. Just to run very, very quickly through the EBC recommendation of bifurcation stenting, we achieved it over the years. This is the first consensus statement introducing the Medina classification, which made a common language for discussing this bifurcation anatomy, which makes it more easy to compare studies of different techniques. In 2008, we came up with a discussion of the fractional mathematics behind flow dividing vessels in the human body. And the main important thing for bifurcation stenting here is actually that a main vessel crossing a side branch will always be tapering, which means that the lower diameter is less than the proximal diameter. And since a stent is a tube, it might cause some problems if you insert the stent with reference for the proximal diameter, because this might make what we call carina shift and close the gap here. And again, the next consensus in 2012, we elaborated on how to solve that problem, and the discussion of the proximal optimization technique was described in details, put in the stent with focus on the distal diameter, which will make a gap here, take a high pressure balloon, short, make a proximal optimization without touching the distal part and without touching the carina area, opening up the access to the side branch in that fashion, which is the POT technique, how to turn a tube until a tapered stent, which is one of the basic achievements we have got in the EBC, and which is actually the basement of why we are advocating a single stent approach in bifurcation stenting. We elaborated a little more in the last year's consensus statement how to do a provisional stenting, 2 wires, predilatation, implant the stent with a reference on the distal diameter, rewire, maybe make a kissing after the pot, and then you have the result. Or the other way around, do the initial implantation, rewire, do a side branch implantation, and then a proximal optimization again, which is pot, side, pot technique. There has been a lot of discussion of what that would do with the flow divider. We have always discussed, at least in 2 stent techniques, that you should do kissing balloon to put the carina in the metal carina in the middle again. But when you're using only 1 stent and stick to the 1 stent solution, pot, side pot may be an option. And it will at least make left main stenting much more easy if it's possible to use only 1 stent in the left main. So, what about the left main? Because bifurcation we have been discussing a lot, but the left main is another animal, and it's very difficult to compare directly from more distally bifurcation when doing the treatment. Of course, it's the largest bifurcation supplying most of the left ventricular myocardium. The side branch is the circumflex, which is not really acceptable to occlude. It might deteriorate the patient very quickly because of mitral regurgitation and ischemia in the papillary musculature and other problems. It's the only bifurcation with takeoff from the aorta, which means that you have in one end of the treatment an osteal lesion, maybe at least an osteal area, with elastin and a possibility of improved post-modulation of the stent. The left main have a large diameter, and most often more than the common produced stent have. The left main is short, there's trifurcation, and the bifurcation angle is generally large, and the left main diameter can be above the maximum dilatation capacity of available stents. So, we recommend, and I'll do it quickly now, the pot technique, remind the gap. If you need another stent, there are 2 options. If you think you have wired the most proximal strut, go further on with the 2 stent techniques, tap culotte or internal cross. Or if it's the distal strut, the anatomy is more suitable for T-stenting. It's lined out here. The difficulties, if you would like to take care of the bifurcation with the 2 stent technique on beforehand, the DK cross is the most safe and effective procedure. And so on with the reverse techniques. Remember that stents are different, and remember that most stents have, at the available stents now, have dilatation diameters up to nearly 6 millimeters, which make them suitable in the left main. And again, there's possible to make quite nice holes for the circumflex as well. Remember that it's much more easy to take a higher stent with a low implantation rate than a small stent with a high implantation rate, pressure. And remember the gap when you do the pot in the left main, because if you lose the wire, it would be very easy to go behind, and then you'll have a quite stent thrombosis-prone catastrophe after dilatating. So, do the pot, and after that, if you're in doubt and if you face problems during the implantation techniques, use intravascular imaging to see and solve the problem. So, having said that, and in sake of time, I'll skip these and go back to the initial conclusion after the EBC meeting in Rotterdam. It is strongly recommended to have access to intravascular imaging when doing elective left main stenting, IVUS, OCT, OFDI. And of course, it's very strongly recommended to use intravascular imaging if a complex left main PCI or PCI and other bifurcation don't go smooth, because you could be behind stent struts and you could solve the technical matters very easily, especially with the OCT. So this is the final slide, just to run through all the steps in what we advocate. Go provisional and use the step as just shown you. Thank you very much for your attention and your time.
Thank you so much, and thank you. Questions or comments? Actually, it's a question. Thank you, first of all, very much for so fantastic presentation. But for me, it's a big discrepancy, and I'm also, as you know, from first bifurcation club in 2004 in Bordeaux, and then we discussed that everything is based off angio I mean classifications, doesn't mean which one. I also know you based on angio classifications, you recommend how to use one or other stents. Do you, and I mean, do you think that now it's time to move it and to go and based on imaging to recommend stent usage?
Well, yes, you know I do, but it is in discussion, and I think it will be the way we move forward. Actually, what we see here is two-dimensional images, and we try to make it three-dimensional, maybe even a four-dimensional picture of a bifurcation. Remember that the bifurcation moves during the heart cycles as well, so it's just not a fixed thing, it's a moving thing. So it's very difficult in a two-dimensional way to elaborate correctly.
Because I guess this is the Excel and Noble know and understand much better because it's really more focused of left main, and there is the problem. If you look on why it is there for so low syntax score, is so bad result for PCI. It is because syntax score by itself gives you very, very low rate of points.
Yeah, totally.
And that means that actually our techniques for left main intervention is not very good.
Totally correct, yes.
Yeah.
But we have to be aware of it, because it would be a treatment that will increase tremendously in the year to come. So we just need to be better in the technical issues and the evaluations.
And imaging.
Yeah, OCT.
One quick comment. The syntax trial was also born at this meeting when Jim Tobin, Fred Moore, and Patrick got together.
You see.
Yes.
Okay.
Okay, thank you, Jens. And